I'm Dr. Michael Latola.
And I'm Megan Strong.
This week's case of the week is a case of diminishing returns on the diatrib.
And find out why a California dentist made the evening news for not allowing a female patient to do this.
And a Mexican dentist gets busted in Nevada and claims he didn't know you needed a U.S. license to practice here. That and more on today's Chairside Live. Hey now, hello and welcome to episode 103 of Chairside Live. Megan, how are you feeling today? You were a little sick last week.
I think little would be an inappropriate term because I was massively ill.
You were barely sick. I saw the numbers come back from. I actually ran some independent tests with your doctor. And on a scale from 1 to 10, you were at 2.5. I didn't want to tell you because I could tell you were suffering. But
no.
And how pregnant are you now?
I'm 34 weeks today.
Wow.
So there's 6 weeks left until 40 weeks, which is the full term.
Mm-hmm.
But really after like 36-ish weeks, it's kind of like, well, whenever.
Right.
Which is both exciting and terrifying at the same time. But so my time here is limited.
Mm-hmm.
So I know you're all going to miss me so much.
Yeah, we are. We're already starting to grieve in our own ways.
Right.
Mine is by celebrating, but really I'm just hiding the sadness that I feel inside. When I was growing up, women were pregnant for 9 months times 4 weeks is 36 weeks, and now it's 40 weeks. And it reminded me at my daughter's high school graduation, they were giving awards to kids who had GPAs of like 4.2. Right. And I'm like, when did this happen? How can I compare how I did in high school to how my kids did if they can actually get a higher GPA than I ever could? And it's the same thing like pregnancy, going from 36 to 40. It's all this new math, and frankly, I'm confused.
Do math, so.
What I'm not confused by, though, is our case of the week. And it's an interesting one where a dentist sent in a couple impressions, and we couldn't quite read the margins. And so we called the doctor, and we said, would you like to trim these margins or take a new impression? He said, I'd be happy to trim the margins. And we got back an interesting result that I want to share with you. In fact, let's take a look at that now. I was meandering through the Bruxer department the other day, and I looked down and saw this impression. And, you know, one of the things that I don't like about plastic trays is how easily when we pour them, the mesh will tear sometimes, and, you know, they just kind of fall apart. But that's really kind of a side issue with this case. It's just something that I've observed that I don't see happen with the metal ones where we have a little more integrity in the tray itself. But that's, again, neither here nor there. I'm just throwing that in there because I noticed how easily this fell apart. And so as we look at this impression for these two posterior crowns, we can see that we're really missing a lot of detail over here on the facial surface of the first molar. And second molar might be a little better, but there's kind of a void there as well. And so as you look into the box, the doctor actually sent a second impression in case that one wasn't really clear. And again, you know, when we see something like this, when we look and we see wash material simply just over the two preps and nowhere else in the impression, and when you can tell that it was done at two different times, you know, a two-phase impression. So this was taken first, this material set first, and then it was relined with this material. Because you can see the separation between the two if you just tug on it a little bit. And when these two materials set simultaneously, that doesn't happen. You just can't peel these apart. And if they set simultaneously, then it doesn't matter if there's not much orange material here because they set at the same time. But if this was allowed to set first and then it's relined with this, the chances of a double impression are just too great where it won't seat and the patient can't close all the way by just adding some more material there. And unless there's an awful lot of relief done here, but I can still see purple. If everything was in orange, you know, perhaps there was enough relief. Like in dental school, we did two-stage impressions where we took the first one, well, we put a piece of like saran wrap over the arch, take an impression, but then we'd come in with a watermelon burn, a slow speed, and hollow all of this out. So this was basically acting now as a custom tray. Of course, it was with putty, not with heavy putty at the time. And then the impression would be all essentially one color because you wouldn't seat it enough to get down to the putty. So a second impression came in. And again, we can see we've got some issues on the buccal of this tooth. We have the mother of all pulls over here on this side, and that looks like it's from fluid coming out over on that side. And again, this did kind of separate from that tray as well, just during the one pour. And again, as we look at this, it's clear that these two materials did not set at the same time. You can tell just by looking at it. you can really get a feeling for the fact that, oh, these did not set simultaneously, because it just looks, it has that certain kind of look to it at times where you're like, yeah, that didn't set, especially when you look at the outside of it more so than the inside. Like if you cut through it on here, it'll do all right in certain areas, and other areas it won't. So we poured up a model for this, and when we poured up the model for the first impression, it looked a little like this, where we had that indistinct kind of buccal margin on the first molar. And actually, I take that back. That's the second one. I just noticed the mother of all pulls on there. So pardon me. Here's the first one. And you can see it really is kind of indistinct here on the first molar. Not that it's totally distinct on the second molar, but the second one is where the first molar looks a little better, but the second molar now has the mother of all pulls that we saw there in that impression, that big thing coming off of there. And so our technicians, call the dentist and, do you want to take a new impression? And the dentist will say, well, try your best. And our people say, all right, well, we'll try this. And so they tried to trim it. And this is what they came up with when they trimmed it. And if you look at this in relation to, say, well, we'll look at it in relation to both of them, but in relation to the first model, you can't really see much there. So they use this one for the second model. You can kind of see where the margins on that second model come down and slope down like that. And you can see actually on the second molar, you can see there was a cord there. You can see some space between the prep and the gingiva. Not a lot of space, but space. But something was there to create that separation. But then over on the buccal, it all kind of falls apart. And a little bit on the distal too, we really can't see it. But on the lingual, we can see that separation. So they trim it and they end up with what you see here for that second molar, which is probably a reasonable facsimile. I trust the technicians to actually trim this, because they're unemotionally attached to this. When they trim it like this, they're just trying to see where the line goes. They're not trying to make it pretty. They're not trying to recreate what they wanted to do in the mouth but weren't able to do in the mouth. So then they use the other model, the other impression, I should say, to pour this model, and then use this to try to get the first molar, because the second molar had this mother of all pulls there and was kind of indistinct. And so they looked and kind of took a guess that this is what the first molar was going to look like, and they thought, you know what, this just feels like too much guessing. So they called the dentist and they say, would you mind trimming it if we sent the model to you? And dentist said, no, absolutely, I'd be happy to do that. And this is the model that we got back from the dentist. So it looks markedly different from what our technicians did, who kind of make a living doing things like this. So you can see where it drops down really far on the distal compared to the mesial. And if we looked at the untrimmed model, it doesn't really look like it dropped, but it's hard to tell. I mean, it's so indistinct. But the more amazing one was to look at the second molar here, and you can see what the second molar prep looks like. And then to see what happened to the second molar when the doctor trimmed it, it just shrunk. The tooth just kind of disappeared. And so all of that was there on the second molar, you can see how wide that tooth is when our technicians trimmed it. It's just gone. It's just literally gone. And when you look at the unpoured model for that, the untrimmed model for that, you can see how wide that tooth was, and the tooth clearly comes down on the mesial buccal. You clearly see that root come down on the mesial buccal, and now it's just not anymore when the dentist trims it. And so the technician showed it to me and said, well, how could a dentist forget a prep from last week? I was like, last week? I forgot the preps from this morning. We don't memorize the preparations and go, oh yeah. I mean, you might see it and go, oh, that's interesting. But better than that, I think, is instead of having the dentist trim it, is let the lab trim it themselves. And frankly, if the lab can't see the margins well enough to be able to accurately trim it without having been there, which means they have to just rely on the quality of the impression, to me, rather than sending it to the dentist and saying, can you trim it, which is really just a way of saying, we're not going to use our no-fault remake policy anymore, because if you trim it and the crowns don't fit, then you are going to have to pay for a remake. If the technicians can't see the margins well enough from the impression to trim it themselves, that's just an automatic new impression that needs to be taken. And I'm sorry, doctor, but that's really what should be done. That doesn't always happen here. Sometimes we'll cut the dentist some slack. Again, on that second molar, you look at the lingual, you can follow that margin around. Even on the distal, you go, okay, I got it. And then we come around the facial. It gets a little indistinct there as we move into the furcation. But then back here, we've got separation again where it looks like there was a cord as that comes down there. And you can see the dentist just amputated that when he trimmed this die. Now all of a sudden there's some dinky little tooth that's there. And I just refuse to believe that this is not actually tooth, because you can see the sulcus here. That's tooth. And that's not a bad prep for a second molar. I mean, there's nothing wrong with that, and we can clearly see it. But sending it to the dentist to do the die trim clearly did not solve the problem. In fact, it really compounded it. And when I look at the way that our technicians trimmed it, I think, when they asked me what should we do, I said, well, you could make it off, this one, and we know it's not going to fit because that dinky tooth does not exist that way. And frankly, I like the way that our people trim this one as well. I said, I don't know, you could, if you make them on here, the dentist is going to have to pay for a remake, and if you make it here, it's going to be free to the dentist if it needs a remake. So I think they're going to do one of both, actually, but I think they should just do it on this and send it back. But really the point is, when you see cases like this, and if your lab calls and asks you to trim the dies, I just want that to be kind of a red flag in your mind of, all right, I need to take a new impression. I mean, because are you really going to remember exactly what those margins look like? Are you going to be able to take an untrimmed model and unemotionally trim this and try to make it accurate, as ugly as it might be with margins going all over the place? Or are you going to trim it with a little revisionist history and try to make it look a little better or a little more normal or a little whatever? And so if a lab calls you to trim your dies, and unless this is something you've been doing for a long time and trimming your own dies, that's fine. But I feel like on an impression, the margin should be so crystal clear that a technician with 2 weeks of training should be able to sit down and trim your very, very obvious margins. And if you don't intend or don't want to trim your dies and the lab's calling you, asking you, hey, do you mind trimming the dies on this case? I would go ahead and translate that into dentalese from English and say, you know what, I should take a new impression on this case. We're probably going to end up with a better restoration, a longer lasting restoration, and a happier patient when it's all said and done.
Thank you for that, Dr. D.
You are welcome.
Wow. And now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Naguib Bari, and he writes, Dear Dr. Datola, thank you so much for all you do to educate us wet gloves dentists that do not have the time or resources to do our own research. I appreciate all you do, and I enjoy working with Glidewell and have had fantastic results. I'm writing today to inquire about an issue I've experienced 3 times so far. One of my patients came back last week with their Bruxer crown off that needed to be re-cemented. I delivered it back in August 2011 with Maxim Elite cement from Kerr. I don't think I knew about Ivoclean and Monobond Plus at the time. The crown came off and the cement came out separate from both the tooth surface and the crown surface, as if it did not bond to either surface. I'm concerned since I had cemented a lot of this type of crown before I started using those 2 products, and am concerned that I will be experiencing this problem again and again. Thank you so much for your time and efforts.
Well, Naguib, and actually he did send a picture along, and you can see a Bruxer crown, and you can see the cement out of the Bruxer crown.
Yes.
And it's neither bonded to the tooth or the crown. In fact, it looks like an exact replica of the shape of the inside of the crown, and it's not bonded there. And this was an issue that we had early on before we even knew about the contamination of zirconia. And so this is a clear case when I look at this and see it that fits the explanation that we currently have of if a Bruxer crown gets tried in the mouth to check the contacts and occlusion, and they always do, and gets contaminated with saliva, and that saliva is not removed, you're going to have a difficult time bonding to it. And in this case with the Maxim Elite, a resin cement, it really won't bond to the Bruxer even if you didn't try it in. So think about this for a minute. The zirconia oxide, of which Bruxer crowns are made from, is very hydrophilic. And of course, resin cements, all of them, including Maxim Elite, are very hydrophobic. They hate moisture. So you put a resin cement together and then a hydrophilic material like zirconia oxide, and they will just never stick together. Hence the need for a zirconia primer like Z Prime Plus, for example, from Bisco. It's got a hydrophilic end on one end of the molecule that bonds to the zirconia oxide, and it's got a hydrophobic end on the other end of the molecule that'll bond to the Maxim Elite. So that would seem to solve the problem. That was the initial recommendation we made to people. But then, of course, what we didn't know when you try the zirconia in the mouth and the salivary contaminants, the phosphates in there get bound down to the zirconia. Even putting the Z Prime Plus in at this point will not stick to the zirconia because all those bonding sites have been taken up by the salivary phosphates. And that's when we learned about sandblasting and or IvoClean, just depending on what you have in your office if you have a sandblaster. And so, yeah, unfortunately, there may be more of these that are going to come off in your office. So that explains why the cement came out of the crown, and we'll get to why it came off the tooth in a minute. This particular crown, for example, what would I do if it came off like that? I'd sandblast the inside of it. You can use the IvoClean 2 if you wanted, but the sandblasting is plenty. You could use the IvoClean by itself for 20 seconds. That's going to be fine. So if you wanted to try it back in the mouth, if it had been out for 5-7 days or something like that, you could. Feel free to try it back in the mouth and take it out and then sandblast it or IvoClean it. And once you've done that, you put the Z Prime Plus on the inside, and then you could use whatever cement that you wanted here. I go a step up from the Maxim Elite. So when you look at a shorter crown like this that's got a short clinical prep and maybe not a ton of retention on the tooth, if you want to bond it in place, which you did with the Maxim Elite, that happens to be the weakest method of bonding because that's a self-adhesive resin cement. And a self-adhesive resin cement is a resin cement that has the self-etching mechanism built into the cement. I would go a step up from that to get a stronger bond to the tooth, and I would do that with Multi-Link Auto Mix or Panavia F 2.0. These are both self-etching resin cements where you take the two bottles, mix them together, stir it up, put it on the tooth for 60 seconds, evaporate it, then mix your cement and put it into place. And you will get a higher bond strength with that class of cements than you will with these self-adhesive resin cements. I'm pretty darn sure, I mean, I can't say this for sure, but I'm pretty darn sure that had you used one of those two cements or that class of cements, the self-etching resin cements like the Multi-Link Auto Mix or like the Panavia F 2.0, that the cement would have stayed on the tooth and the crown would have come off clean and the cement would have stayed on the tooth. But the self-adhesive resin cements, it's the weakest way to bond something in place. So when you want to step it up and really want to bond something into place, I would go with the self-etching resin cements. And there is one last thing you can do in a situation like this as well. You could take the crown, try it back in the mouth, make sure everything's fine, and you could take it out. And then after you sandblast it or after you put the Z Prime Plus in it, you can, and in fact, you know what, let's look at this from a new crown perspective because that's a little easier way to look at it. Let's say you've got a new crown back from the lab. Let's say that crown fell off and the patient lost it. You take a new impression, get a crown back from the lab. You can also take the Bisco Z Prime Plus and place it inside of the Bruxer crown before it ever goes in the patient's mouth. So we've taken Z Prime Plus, we put it in a clean Bruxer crown right out of the box, and so the hydrophilic portion of the Z Prime Plus is now bound down to the Bruxer crown, and we've got the hydrophobic end sticking out waiting for the resin. But before we go to cement, we have to try this in and make sure it fits. So as we try this crown in the mouth, because we've got it coated with the Z Prime Plus and everything that's outward facing is hydrophobic, the saliva that's on the prep cannot get to the zirconia crown, and it will not bond at all to the Z Prime Plus. So by putting Z Prime Plus inside of the crown and then trying it in and doing contacts and occlusion, you don't have to worry about contamination of the crown anymore. And as soon as you're happy with the contacts and the occlusion, you just take the crown out, rinse the inside out with water. It's just going to bounce off that hydrophobic layer as well. Dry it, and then go to your resin cement and go into the tooth. So that's actually the easiest way probably to do this whole procedure. In fact, we toyed with the idea of coating all the crowns that we sent out of the lab, all the Bruxer crowns, with something like Z Prime Plus. But there's a shelf life to it, so it may not be active if you go to seed it, say, after 10 to 14 days. And there's a lot of dentists who prefer the ease of use with the Ceramer cement from Doxadental. And if the Z Prime Plus is already in the crown, the Ceramer will not bond to the crown. Ceramer cement is a water-based cement, so it's very hydrophilic, just like the Bruxer, and that's how those two materials bond together. So if you have a clean, new Bruxer crown out of the box that you want to try in the patient's mouth, you can coat it first with the Z Prime Plus, go through all the steps to check the occlusion and the contacts, and then just simply rinse out and dry it when you're done and go right to your resin cement. So that's an alternative way to do it. So I'm going to knock on wood, or whatever this desk is made out of, whatever kind of pressed particle board that this desk is made out of, and hope that you don't have a lot of these failures. But it could happen, and it's just a lack of knowledge that we didn't know about this contamination of the zirconia. And we also didn't know in the beginning how hydrophilic zirconia oxide was, and that these resin cements would not stick to them without a zirconia primer in between the tube, as we're trying to meld, if you will, a hydrophobic surface with a hydrophilic surface. So you don't know what you don't know. So hopefully you don't have too many more failures like this. And any of the ones that do come off, you now know what to do to put it back into place. So that was great. I'm glad he brought that up. I'm glad he took the time to send a picture along too. And for that, he's going to be rewarded with the Bruxer adjustment and polishing kit for those said restorations, and for sending a photograph in, the reverse prep kit as well.
Wow.
Pretty nice. Do you have anything?
Yeah,
you usually have a visual gift.
Because he sent in a photograph, I've got this. Where is it? Is this it? No, I don't. Yeah, here we go. Right here. Look at this.
Oh, look at me.
Look at you.
Look at me like a 4-year-old who doesn't want to hear his parents saying something. That's right. I can't hear you.
And I believe in this photograph, it was last episode when I was sick.
Very sick, I might add.
Yes. And I was going to blow my nose, which
Right.
I need to do right now, but I'm not going to.
And you did it.
And
But you were embarrassed. You didn't want anyone to hear it.
I didn't want anyone to hear it,
Right.
so you plugged your
Plug
ears.
my ears. But I recorded it with my phone, so I apologize. Listened to it many times since. Don't know why.
It's really weird.
Just enjoy it.
But yeah.
Tiny little you making that big old sniff. So let's sign that and get it out to...
yes, and very generous of you with that.
Well, it's very easy for me to do. I got them for free.
Okay.
Any news today?
Yes. A California mother of 3 says she was told she needed to cover up while breastfeeding at the dentist office. While her one son was getting a checkup, her 7-month-old baby began to cry because he was hungry. So she started to breastfeed. She says an assistant came in and told her to cover up. The dental group said they did not require her to cover up or leave, but simply asked her to cover up since other people were around. California law allows for a woman to breastfeed anywhere, but does not say anything about covering breasts.
Yeah, in fact, it's one of those. There's been crazy things happening in dental offices recently the last few weeks.
Babies being dropped off.
I know, and this is
smashing
another one.
through.
And I really would like to know. I mean, this is a mom who's got a child in the chair, and then another one. So the last thing I want to hear when I'm working on a child is another one crying.
Right.
And so it sounds like the way you read it, that it was in the same operatory where she started to breastfeed. And I'm not sure who asked her to cover up more, if it was just in the operatory and not the reception area.
She said she was in the back room, which...
Like a staff break room maybe, or something like that?
Maybe, possibly that, but that didn't make sense to me because either I thought she was just in the waiting room,
right,
which would make sense that there might be other patients there waiting, but then if it was in the break room or some back room, then I guess the other people that were there, I guess, would have been the staff.
Well, we don't call it a waiting room anymore because that implies people are going to have to wait. That's why we call it a reception area, so they're just going to have to recept for about an hour. If we're behind schedule, you just keep recepting while you're out there. But yeah, so if it was out there, I could maybe understand, but the law actually says that, like you said, a woman can do it anywhere except inside the private residence of another person. So you can't go into somebody's house and just breastfeed in
Without
front of
a
them.
nip. Yeah, no,
if that's what you want to do. But otherwise, it's kind of surprising. I looked it up to see what the picture of the dental office looked like, but it's just a picture of the woman. And I don't know, maybe it's the tattoo that threw people off. Maybe that was the thing that threw, and they said, whoa, but they don't actually specify which side it was. But I'm surprised that the dental office would do that. And in the spirit of cover-up, I wanted to offer something to our dentist for the letter of the week. We've called this before the Chairside Live Apron.
It is.
But this is for our good doctor who wrote in for viewer mail, who's from Upland, California. This is the Chairside Live cover-up. So if you have a mom in with a patient in California like this happened, and you feel like you're seeing too much, you just place this over the mom. It'll cover almost anyone. Perfect. And including the baby. Or you can use with it to barbecue on the weekends, or both. One in the AM, one in the PM, whatever you want to do.
You know, I of course, like, if I'm all for the law that allows women to breastfeed wherever, but I am in the camp that believes that there should be some sort of, like, blankety thing. Mm-hmm. Like, I just couldn't personally imagine just being so open and just, here we go, just let's do this.
Right.
I would definitely I even registered for one, like a little, it's like a cute cover-up thing.
Right, and I got it for you.
Okay.
I'm glad you registered,
Thanks.
and here it is. This canvas is a little rough around the edges, perhaps. But, I don't know. I feel like sometimes we're a little prudish about that. I mean, there just seems a little difference to me between this and, say, Girls Gone Wild. For example, which are both kind of the same. It's weird how one gets you in trouble and the other one makes you millions of dollars in DVDs. But it seems to me like there's just kind of I don't know. I mean, it's not for voyeuristic purposes or the woman's trying to be an exhibitionist. I mean, I'm just not sure how I feel about it. But I guess the bottom line is if it happens in your dental office, be careful. Because this was a news story that was running like on Channel 13, the CBS affiliate throughout California.
Sure.
And just be careful. I mean, especially if if she just walks in off the street and starts doing it in your office, that's one thing.
A little bit.
But if there are patients of record and there's another kid being seen, let's just, whatever. Grab a lead apron, throw it over.
Right.
That might be a little strong.
Yeah,
the Chairside Live apron.
Let it happen.
Is a little bit. I'd say let it happen and don't worry about it, especially if it's in an operatory.
Yes.
Anything else?
Yes. A Las Vegas man was arrested in connection with narcotics found at multiple unlicensed medical businesses. While investigating an illegal dentist office, police found a large amount of narcotics inside several unlicensed businesses connected through a common hallway. Police say they found tranquilizers and hormones, all with Spanish labels. The man told investigators that he studied medicine in Mexico, where he's a licensed doctor, and that he didn't know how to obtain his license in Nevada and that he couldn't afford it. He said he only gives out medicine and then refers the patient to the hospital, adding that he was the only one working in the cash-only clinic and his patients were mostly family and friends.
I want to go sit down in the cockpit of the next plane that I get on to fly somewhere and then say, I didn't realize I needed to get a pilot's license.
It was too expensive.
It was too expensive. Or, I didn't realize I needed to get a license in the United States. I thought that my Mexican license was a worldwide license. I thought it allowed me to go to any country on the face of the earth
it's not.
And hand out pain medication. It's expensive and it's hard. Right. My dental school actually has a program where if you've been trained somewhere else, you come in for 2 years. You get training in a U.S. dental school. You've already been certified a dentist in another country. Huh. Now you just kind of need to learn what we do here for 2 years. And even then, sometimes they struggle to pass boards, because it's completely different. It's a more rigorous standard, at least it used to be in terms of taking the boards. And it's difficult, and that's really, I think, the thing. So this whole story about I didn't know that I needed to have a license probably doesn't ring true, that you can just, scurry up to the United States and start doing this.
And what's interesting is that they've done some reports lately that show that there are actually a lot of California residents and possibly some neighboring states where, because of the lack of insurance or dental care being too expensive, they will go down to Mexico to get treatment. Right. And so he could easily practice down there and have potentially a profitable practice, but nope, he's up here.
I wonder if I went down there, I went to Mexico and I started practicing, if I would ever get busted and they'd say, whoa, you need a Mexican licensed to practice, because I think they would still do that.
Right.
And I think they would be talking about it on the Mexican version of Chairside Live, Chairside Viva. What's chair?
Sia.
A Sia?
No, not I said but it's just Sia.
And what's live? What's side? Can you say Chairside Live in Spanish? No, but you'll be able to by next week. All right, well, that about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
Give me my Billy Idol.
Mer.
We're letting you go. We just haven't told you yet.
It's stupid.
This is the worst way to tell you. I'm sorry. It's hard. But all been rice being thrown in.
Right. I don't think I've ever heard that song at a wedding.
That's the sped up version.
Okay. Sounded more like a
The
circus,
music
but
version. That.
oh wow.
Now it's time for a segment we call Leprosy Update. Part of Megan's lip is coming off.
No, it like peels off because
I know. I'm peeling too. Too much sun. So on behalf of myself, Megan,
James Kwasniewski,
and the rest of the CSL crew,
Hasta luego.